then the clinical result need to be withheld till the appropriate corrective actions are taken. But you have to see in your situation how you are going to manage.
Okay, sir. Thank you.
Okay. So this is all about the session. So this is again for postgraduates. Particularly, this session is very useful because we usually ask in the seminars and in the exams, and they will be clueless about how to put for QCs. So now we will have moving ahead to the subsequent sessions with Dr. Haritha. We will discuss the direct susceptibility test and its implication, and also we will summarize the M100 differences of UCAS and CLSI. So, it is now a time to reduce the turnaround time because blood culture is one of the most critical investigation of your laboratory. And if you go to the bedside, you will see that most of the patient for which the blood culture is sent, those patients are critically ill, and among them many are dying on a daily basis. You sit in the lab, you will not realize. We go to the bedside, then you will realize that if you have received 30 blood cultures today, then every day among those 30 patients, 2 or 3 patients will keep dying every day. Therefore, it is extremely important. It is your duty, your responsibility that you should give the AST result as early as possible, and direct a susceptibility test from directly from blood culture broth is one of the most effective method of initiating the antibiotic therapy immediately after the blood culture bottle is flagged. In JIPMER, after the blood culture bottle flags, the DST report is released within 10 hours of blood culture bottle flag positive. And after the release of the DST report, we go to the bedside and we inform them so that the appropriate change, uh, appropriate antibiotic will be started. Following which, we also do a colony Vitek, and the colony Vitek result whenever it is available, that also we release, and if any change of antibiotic is there, then we report to them. And this strategy we started when Dipasri was there as a senior resident, maybe in 2017 we started, and last 5 years we have seen that there is dramatic change in the outcome of the patient. There are errors among DST and AST, but the errors are very limited, and it is quite safe. And now both CLSA and UCAS have recommended the errors. And CLSA and UCAS both have recommended to use direct susceptibility test. Therefore, you have now evidence that you can go ahead for direct susceptibility test. So, with this introduction, I would like to welcome Dr. Haritha, who will tell the CLSI and UCAS recommendation of direct susceptibility test, following which she will summarize the differences of UCAS and CLSI. Over to you, Haritha.
Good morning, everyone. Thank you so much, sir. Am I audible to everybody?
Yeah, Haritha, audible.
Okay, ma'am. So I'm sharing my screen now. As sir has already explained, I'll be explaining you about the basics of the DST and also the differences between CLSI and EUCAST. Now, coming to DST, what is meant by DST? Can any postgraduate student tell me what is DST? Can any of you unmute yourselves and tell me?
Direct susceptibility testing.
Yeah, so any of you are practicing this direct susceptibility testing in your labs?
No.
Okay, so let us discuss what is this. First thing, the DST means it is a direct susceptibility testing. And are there any guidelines for the direct susceptibility testing for the positively flagged blood culture bottles?
Sharing the board?
Yes,
Are there
ma'am.
any guidelines present or no?
Yes, ma'am. There is.
Yes,
Yeah, so which guidelines are present?
And for CLSI, they have, in 2021, they have published.
Yeah. So both CLSI and EUCAST guidelines are present for the DST from the positively flagged blood culture bottles. Okay, so both the CLSI and EUCAST have given guidelines. So now we'll be learning about what guidelines are given in CLSI and what are the differences between the CLSI and EUCAST guidelines for the DST. Okay, now this DST is recommended by both CLSI and EUCAST, and IDSA has also given few guidelines. Okay. So first, even IDSA says that the direct susceptibility test has to be done for the proper antimicrobial stewardship guidance. Okay. So next, coming to this, there is a CLSI study which is published in JCM 2018. So it tells that the direct from the blood culture disk diffusion to determine the antimicrobial susceptibility of the gram-negative bacteria. Okay. So this is the preliminary report from the CLSI working standards group, and the summary of this would be the direct disk diffusion versus the reference method. So here what they tell is that is the categorical agreement was 87.9% and the very major error was only 0.5%. The major error was 3.5% and minor error was 10%. Okay, so this is what the summary of this study was. The differences between the direct disk diffusion versus the reference disk diffusion. Okay, so following this, one more thing I want to explain. So first, what we need to do. So first, a blood culture bottle flags positive. After that, the gram stain is very important to put the DST. Okay. First, you need to know what organism is it. That is on the gram stain, it is whether it is a gram positive organism or a gram negative organism. So the float, I'll be telling you how it has to be done. Initially, a blood culture bottle flags positive. Okay. After it flags positive, you'll take out the blood culture bottle from the machine and you have to make the gram stain first from that. Okay. Following the gram stain, how do you make the gram stain? You have to mix the bottle properly, the blood and the broth properly. You need to mix 5 to 10 times. Following it, you have to insert the needles and syringe into the bottle. After cleaning the top of the cap with the alcohol swab, you have to take out you have to insert the needle into that and you have to withdraw a little bit blood from that. Okay. After withdrawing the blood, you need to make the gram stain. Okay. So immediately after making the gram stain, you will even do the culture on the blood agar, McConkey agar, and also the chocolate agar. Okay. So after making the smear, what you do, you see the smear. So based on the smear, if you see the gram positive organisms or the gram negative organism, you will put the discs for the DST. Okay, so for the gram positive organisms, there'll be different discs like you feel ciprofloxacin or linezolid or vancomycin you put, and for gram negative organisms, ceftriaxone, piperacillin, tazobactam or meropenem you can see. Okay, so that is why the gram stain is very important for putting the DST, because you need to know which organism is it, whether it is gram positive or the gram negative. So now that is the reason the gram stain is very important. And there was a study conducted in JIPMER, that is comparison of 4 different methods of smear preparation for the gram stain from the positively flagged blood culture bottles. Okay, so this was a study conducted in JIPMER by Dr. Apoop sir and Dipashri ma'am. So following this, now another question for you. So based on the guidelines, that is CLSI and EUCAST, there are little bit differences in them. That is how much amount of blood has to be dispensed for the DST, or how much is the incubation time in CLSI guidelines, the EUCAST guidelines. So first, let us see how much amount of blood has to be used for performing the DST according to CLSI. So these are the options: 1 drop, 2 drops, 3 drops, or 4 drops. So can somebody answer me? What is the answer for this?
4 drops.
Okay, very good. 4 drops. So I think you've already read the guidelines before. So it is correct. It is 4 drops. So, and the incubation time for DST according to CLSI, after you put the discs, for how much, after how much time of incubation period you need to take the reading?
6 to 8.
Yeah, it is 16 to 18 hours. Correct. Very good. And in EUCAST, can somebody tell me what would be the incubation time for the DST?
4, 6, and 8 hours.
Yeah, 4, 6, and 8 hours. And how much amount of blood should be taken there? Okay, that I'll be
150.
Yeah, so that I'll be explaining you. First, I'll be explaining about the CLSI. That is the CLSI disk diffusion test from the positively flagged blood culture bottles. So always remember, this guidelines is given only for the enterobacterials. Okay, it is not for the others. It is only given for the enterobacterials. So what happens first, after the blood culture bottle flags positive, you need to remove it outside from the machine, and we have to invert the blood culture bottle 5 to 10 times to thoroughly mix. Okay, the blood and the broth has to thoroughly mix. So you need to mix it with 5 to 10 times. Following it, sterilize the top of the bottle with an alcohol swab. Okay, the top of the cap of the bottle has to be sterilized with the alcohol wipe. Following this, what we do, we have to insert a 20 gauge needle. Always remember the size is very important here. Okay, the 20 gauge is very important because there is the particular inoculum which is required only will be transferred here. If you take a big or small size, the amount of blood may also differ and the inoculum size may also differ. For that reason, only a 20 gauge needle you need to take and dispense 4 drops of the blood culture broth onto the MHA plate, and we have to spread across like the lawn culture. Okay, so yesterday in the basics of the AST, as ma'am and sir had explained already, we have seen what is lawn culture. We have to rotate the plate around 60 degrees and swab it thrice. Okay, so all of you know this. So it is the same. We have to dispense 4 drops of the blood culture brought into the MHA plate, and we have to spread across like the lawn culture. So following this, what we do, we have to open the lid ajar for 3 to 5 minutes, okay, just for the blood to dry over the plate, okay, but it should not be more than 15 minutes. It is always less than 15 minutes, okay, and for maximum of 3 to 5 minutes. Following this, you have to place the discs onto the medium. Okay, the antibiotic discs have to be placed on the medium, and the plates have to be incubated in the incubator for 16 to 18 hours, after which the reading has to be taken. So always remember, one more important point here is the maximum incubation time is 16 to 18 hours, after which the reading has to be taken. Before 16 hours, the reading should not be taken. Okay, so these are the important points here. That is, the 4 drops of blood culture broth has to be taken, and within 15 minutes, it has to be left for at least 3 to 5 minutes or maximum up to 15 minutes, not more than that, following which the discs has to be placed and it has to be incubated minimum for 16 to 18 hours. Okay, and the CLSI has also given few antibiotics for which this has to be done. That is, the direct disc diffusion can be done. That is for ampicillin, aztreonam, ceftazidime, ceftriaxone, tobramycin, and cotrimoxazole. Okay, so these are the drugs for which the CLSI tells that the direct disc diffusion from the blood culture bottles can be done only for the enterobacterials. Now coming to the QC which we use here is the ATCC E. coli 25922. Okay, so this is the QC which has to be used, and organism group I already explained you, it is only for the enterobacterials and inoculum. Now as soon as the blood culture bottle flags positive, it should be used within 8 hours of flagging positive. Okay, maximum up to 8 hours of flagging positive, the DST has to be done. Okay, fine, all of you understood, clear with this?
Yes. So what to do regarding carbapenems if it can't be tested by DST?
Carbapenems can be tested, right? Meropenem and all we normally test by the DST.
Okay. In your list, I think it was not there, the previous slide.
Yeah,
Can you please show the
according,
previous one?
according to the CLSI guidelines, they tell that these antibiotics only has to be tested. But there's a study which is done in JIPMER again. Okay, it is the evaluation of performance of the direct disc diffusion test from the positively flagged blood culture broth. So as sir has already told, they have conducted a study in JIPMER 5 years back, showing the results for this. And they have conducted for all the groups and all the antibiotics like the Enterobacteriaceae, Pseudomonas, Acinetobacter, Staphylococcus, Enterococcus, for all of these. And they have compared the direct disc diffusion to the reference disc diffusion. And they have found that the categorical agreement was above 95% for all these. And the my major error, very major and minor error was also less than 5% for all of these. So now we generally follow this. After the study, we have seen that the results are very good and the categorical agreement was also above 95%. So that is why we have validated it and we have started using for all the drug bug combinations.
Okay.
Okay, even though the guidelines don't tell, we have validated it and we have started using it.
Yeah, thank you.
Yeah. So this is the CLSI guidelines which show the direct disc diffusion test. Now coming to the EUCAST. So let us see what the difference is in the EUCAST here. So the EUCAST call it as RAST. There we call it as DST. Here they call it as RAST, that is rapid antimicrobial susceptibility testing. Now let us see what are the differences here. It is validated by using the blood culture broth for BACTEC, BACT-alert, and also Versatrec. It has validated for all these 3 things, and both aerobic and anaerobic bottles can be used in this. Okay, they are validated for both aerobic and anaerobic bottles. Now coming to the test procedure here, here what we need to do is, there it was in CLSI 4 drops was used. Here it is 125 plus or minus 25 microliters of the positive blood culture broth has to be put on the MHA plate and spread across the lawn culture. So here the amount of blood is differing in EUCAST and CLSI. And following this, we have to place the discs onto the medium and incubate the plates for 4, 6, and 8 hours, after which the reading has to be taken. So this is very important. The CLSI has told the maximum incubation time is 16 to 18 hours and the minimum is at least 16 hours, before which the reading should not be taken. But here, according to the EUCAST RAST, they are telling that the reading can be taken after 4 hours, 6 hours, and maximum is up to 8 hours. After 8 hours, the reading should not be taken. Okay. So how the reading has to be taken, we'll see. Before that, the RAST is validated for storage of blood culture bottles up to 3 hours in room temperature and up to 18 hours in the blood culture instrument. Okay, so this is after it flags positive. It is validated for storage up to 3 hours in room temperature and up to 18 hours in the blood culture instrument. Now coming to the incubation conditions, so this is the list of the organisms which the EUCAST has also given and the incubation time. So they tell that the organisms like E. coli, Klebsiella, Acinetobacter baumannii, Staphylococcus aureus, and for Enterococcus faecalis and Faecium, the incubation time should be 4, 6, and 8 hours. Okay, so the minimum incubation is 4 hours and the maximum incubation is 8 hours. For Pseudomonas aeruginosa, they have given 6 and 8 hours. That is the minimum, it should be at least for 6 hours, not less than that. And for Streptococcus pneumoniae, again they have told it is 4, 6, and 8 hours. So for each organism, specific incubation time they have mentioned. So can you answer me this? The maximum incubation time for DST according to EUCAST, after which the plates should not be read.
8 hours. 8 hours.
Yeah, well.
Very good. It is 8 hours. I've already
8 hours.
told. Yeah, it is correct.
8
It is 8 hours. Yeah. So let us know the explanation for this. Okay. So what they normally tell is, after the growth comes, we have to read the inhibition zones from the front of the plate after removing the lid. Okay. So it should be like this. You have to remove the lid and from the front of the plate, you have to take the reading. Okay. And read only when the growth is confluent and the zone edges are clearly visible. Here you can see 2 discs, right? The disc which is present above, that is the first disc above, you can see the clear zone. Okay. The clear inhibition zone you can see. So if the zone is like this, you can take the reading at 4 hours only. If at 4 hours, the zone is clear. Now down the Cipro disc, you can see the zone is fuzzy. The zone is not so clear. So whenever you see that after 4 hours, the zone is fuzzy and not clear, you have to further incubate for another 2 hours, that is for 6 hours. And again, and after 6 hours, you can take out the plate and you can take the reading. Okay. But when you find that after 6 hours also still the zone is fuzzy, the zone is not clear, then you further incubate for another 2 hours, that is for 8 hours. And after 8 hours, you take out the plate. And if you find the clear zone, then you can take the reading and you can give the DST. But if you still find the zones are fuzzy, EUCAST tells that after 8 hours, the plates should not be further incubated. So you cannot take the reading, you cannot further incubate the plates after 8 hours. So at this time, the zones are still fuzzy, you cannot take the readings. So you have to wait for the AST, that is from the colony which AST you have done. You have to wait for the AST result only, and this DST result cannot be given. So is everybody clear with this concept?
Yes.
Okay, so maximum up to 8 hours only you need to incubate the plates, but after 8 hours also, if the zones are still fuzzy, then the DST result cannot be given and you need to wait for the AST result only. Okay, so this is what this explains. And even the EUCAST has given us a specific document for this, that is the zone diameter breakpoint for the rapid, that is for the RAST directly from the blood culture bottles. It's a separate document given by EUCAST, giving the zone diameters and the incubation times and showing after which incubation time how much the zone diameters should be. For the RAST only, they've given specifically a document. So here you can see for E. coli, they've mentioned certain time, that is after 4 hours, the sensitive diameter should be like the 17. If it is more than or equal to 17 mm, it will be susceptible. After 6 hours, it should be 18, and after 8 hours, it should be 18 mm for the susceptible. So this is how the EUCAST has given a separate document for the for the DST. Okay. And and it has also given for certain organisms for which this RAST can be performed. That is only for E. coli, Klebsiella pneumoniae, Pseudomonas aeruginosa, Staphylococcus aureus, Streptococcus pneumoniae, Enterococcus faecalis, Enterococcus faecium, and Acinetobacter baumannii. So these are the organisms for which the RAST can be performed according to the EUCAST guidelines. So now the QC according to CLSI it is only the E. coli 25922 stain with which the QC is done. They have not given any specific method how it has to be done, but EUCAST has given a specific method. So in the diagram here, we can see how they have explained. The first test tube which you can see, first what you need to make is you need to prepare a 0.5 McFarland, the QC stain. Okay, so whatever the QC stain you're taking, you need to make a 0.5 McFarland suspension of the QC stain. Following this, in the second test tube, you can see there is 1 ml of the saline. Okay, so what you need to do is this 0.5 McFarland suspension of the QC stain, whatever is made, 1 microliter from this you need to take and you need to add to 1 ml of the saline. Okay, 1 ml of the saline which is there in the second test tube. Okay, in the third test tube, again you need to take 1 ml of the saline, and what you need to do is the second tube, the second test tube, whichever is there, from here you need to take another 1 microliter and add it in the third test tube, that is a third test tube of the saline. From this you need to take 1000 microliters of the suspension and add it into the blood culture bottle. Okay, so this is what the procedure they have told. That is, first the 0.5 McFarlands of the QC stain you'll be taking, then 1 microliter from this you'll be adding to 1 ml of the saline. Following this, you need to mix the suspension properly, and then 1 microliter again from this tube has to be suspended into the third tube of 1 ml of the saline again. And you need to mix the suspension properly again. And from this again 1000 microliters is taken and it is suspended into the blood culture bottle. Okay, so the final volume which is present in the blood culture bottle will be 1 ml of 100 to 200 colony forming units per ml of the suspension of the solution will be present. Okay, so this is the QC recommendation according to the EUCAST RAST which you need to follow. And following this, you need to do the QC as I've explained previously. That is the method for the RAST, whichever is there. After this, you can perform the RAST as usual. Okay, so this is the basics of the DST. So everybody is clear, or anybody has any doubts regarding this DST and RAST?
No, ma'am.
In case of RAST,
Yeah.
you are using MHA or isosensitive agar only?
Your voice is not clear. Can you just repeat it once again?
In case of EUCAST,
Yeah.
are we making use of MHA or isosensitive agar only?
MHA only they'll be using. Here they've mentioned it is the same MHA only they're using. In this slide I have shown, yeah, the incubation and the plates they've shown. For the gram negatives and for enterococcus also, it is the Muller-Hilton agar only. And for streptococcus pneumoniae, as we normally use the Muller-Hilton blood agar, whichever is there, that has to be used.
Okay, thank you.
So coming to the next topic, the major differences between the CLSI and EUCAST. So yesterday, whenever the topics were taken, that is by Dr. Ketan, Dr. Dipashri Madam and Apurva sir, then and there they've already explained the differences between CLSI and EUCAST, the zone diameters or whatever were there. So now I'll be just explaining superficially the other points regarding the differences between the CLSI and EUCAST. Okay. So before that, let us answer a few questions. First is the breakpoint for colistin according to the latest CLSI 2021 guidelines is given as. So what would be the option here? A, okay, yeah, correct. It is intermediate and resistant. There is no sensitive breakpoint as of now. Okay, according to EUCAST, what would be the option then? The same question. According to EUCAST, what would be the option?
Again, A.
SNR.
S&R, very good. It is S&R. So according to CLSI, the breakpoint for colistin is I and R. And according to EUCAST, it is still S&R. They don't have the I breakpoint. Okay, so second question, the percentage susceptible includes which of the following according to EUCAST? Percentage susceptibility means what according to EUCAST? What would be the option here?
B.
Second.
B.
Second option.
B.
B.
Yeah. So here
S
B
plus
would,
I.
yeah, S plus I, very good. S plus I. So all of you already know the differences between CLSI and EUCAST. So let us quickly go through.
Yeah.
These are the major differences. The first one is the role of FDA. What is the role of FDA and CLSI? It has a major role in determining the breakpoints. Okay, so FDA determines the breakpoints in the CLSI, but in EUCAST, the FDA has no roles. The EUCAST is functions as the breakpoint committee for both EMA and ECDC. Okay, so this is one of the difference. And coming to the role of industry, the CLSI has it has a part of decision process, but this has only a consultative role according to the EUCAST. Now coming to the documents also, whenever you see the CLSI documents are always for sale, they are not free. We need to purchase the documents. But according to the EUCAST, all the documents are free and they are freely downloadable from the internet. And coming to the number of meetings, the 2 meetings per year are conducted in CLSI, and in EUCAST it is 5 per year. And the documents on the breakpoints background, that is how they have created the breakpoints, that is for a particular drug bug combinations, how they have validated the breakpoints. There are no particular documents for this according to the CLSI. But in the EUCAST, they have given certain rational documents for which, accordingly how the breakpoints are established. See, so this is the EUCAST susceptibility testing, the site which is there. So here you can see the rational documents for EUCAST are present. So the general information is present and template is also present. So they have given the rational documents for all these antimicrobial agents like amikacin, benzyl penicillin, ceftazidime, avibactam. So the rational documents are present for the breakpoints in EUCAST, but not CLSI. Then coming to the next one, yesterday as already Apud sir explained, there are certain report groups or test groups according to CLSI, like the A, B, C, U, O, and I. So I think all of you are aware of these groups. Okay. So these groups are given only in the CLSI. According to EUCAST, there is no such categorization given. Okay. And the clinical breakpoint categories also, in CLSI, there are many clinical breakpoint categories given like S, susceptible, intermediate or susceptible, dose dependent, resistant, non-susceptible, and not susceptible. Okay, so these are the different clinical breakpoint categories available in CLSI. But in EUCAST, they have given a susceptible, a resistant, and another one, the third one, which can also be called as intermediate, is called the ATU, that is area of technical uncertainty. Okay, so these are the 3 things which are given in EUCAST. Coming to the epidemiological breakpoint category, that is called as the epidemiological cutoff value in CLSI and called as ECOF, that is epidemiological cutoff according to the EUCAST. Okay, and the increased dose concept is called as susceptible dose dependent, which is established only for 3 drugs. So can anybody of you tell me, recollecting yesterday's session, for which SDD is present?
Ceftaroline.
Yes,
Cefepime.
Cefepime for enterobacterial. Very good, daptomycin. Yeah. So for these 3 things, a susceptible dose dependent concept is given according to CLSI. But according to EUCAST, there are many drug bug combinations for which this increased dose concept is given. Okay. And as the previous question, as I already explained you, the percentage susceptible is percentage susceptible. That is only the susceptible strains are called as susceptible in CLSI. But according to EUCAST, it is both percentage susceptible and percentage intermediate. Both are called as percentage susceptible. And the meaning of not susceptible is the percentage of intermediate and the percentage of resistant strains are called as not susceptible in CLSI. In EUCAST, only the percentage resistance is called as the not susceptible. Okay, and next coming to the pneumococcus and penicillin breakpoints, if it is less than 19 mm the zone diameter, then MIC has to be performed according to the CLSI. But according to EUCAST, what they tell is, I think Dr. Ketan has explained this very well yesterday. So I'll be just briefing it. So according to the CLSI, less than 19 mm the zone diameter is there, then you need to perform the MIC. And if it is less than 19 mm, then you need to interpret the plate again at 8 mm zone, and then you need to perform the MIC. So this is according to the EUCAST. And one more very important thing, phosphomycin for enterobacterials. Okay, so according to CLSI, the disc diffusion or MIC for E. coli and Enterococcus faecalis is present in the urinary tract isolates only. So always remember, it is only for 2 organisms, that too only for UTI. That is for E. coli and Enterococcus faecalis, the disc diffusion and MIC is available. But in EUCAST, the disc diffusion is present for E. coli only, and for other all organisms, MIC is also present. MIC breakpoints are also present. Okay. And coming to the other differences, the colistin breakpoint, previously we've discussed the question. In CLSI, they have the intermediate and resistant breakpoints, but in EUCAST, they have only the susceptible and resistant. And one more important thing, ceftriaxone for Acinetobacter is not given as intrinsic resistance in CLSI. Okay, according to CLSI, they consider ceftriaxone can be reported for Acinetobacter. But in EUCAST, they have given that ceftriaxone is intrinsically resistant to Acinetobacter. Okay, so Acinetobacter is intrinsically resistant to colistin. And also one more example for this, colistin for Hafnia. It is not intrinsically resistant according to CLSI, but EUCAST has given it as intrinsically resistant. So these are only the superficial examples which I have told and the differences between the CLSI and EUCAST. So anybody has any doubts in these topics? Sir, I think it is,
Thank you, Haritha.
yeah.
Those differences of CLSI and EUCAST are not limited to this many differences. For every organism, there are a list of differences. So me and Ketan and Dipasri, Haritha, we all were going through our last couple of weeks. We realized that the differences are there at breakpoint level at every organism. However, the major ones we have displayed here, so that overall you should have a idea about the differences. The very important thing what I want to tell is you are free to choose either CLSI or UCAS, but you cannot or you are not supposed to do a combo business. The meaning is either if you want to use CLSI, you use strictly CLSI, and only for those drug bug combinations for which CLSI breakpoints are not there, you use for those alone UCAS. Like for example, tigacycline alone you can use UCAS. Otherwise, you can follow UCAS strictly for all except those where UCAS breakpoints are not there. You can use the CLSA. But if you do half CLSA, half UCAS, then it will become a problem because the QC recommendations, the methodology wise, there are a lot of differences between CLSA and UCAS. Okay, there are some zone diameters which are sensitive by CLSI. If you apply UCAS breakpoint, they become resistant. So